Hello all. In this session we will study about paraplegia. As I have already told what is paraplegia. Paraplegia, it is the paralysis or weakness of both the lower limbs. Okay, it is the paralysis or weakness of both the lower limbs. This paraplegia that can be a spastic paraplegia or a flaccid paraplegia. Spastic paraplegia, that is due to a UMN lesion, that can be due to a UMN lesion, and the flaccid paraplegia, that is due to a LMN lesion, that is due to a LMN lesion. So in a UMN lesion, the lesion will be somewhere between the cerebral cortex to the anterior horn cell of the spinal cord. So it will be between cerebral cortex to the anterior horn cell of the spinal cord. Next is the LMN lesion. Here the cause will be between the lesion between the spinal cord to the associated muscle, from the anterior horn cell of the spinal cord to the associated muscle. So in a UMN lesion, the cause will be a brain cause or a spinal cord cause. In a flaccid paraplegia, the lesion will be a spinal cord cause or a neuropathy or myopathy. Okay, it can be a myopathy. So now coming to the causes. So a spinal cause, that can be a focal cause, a systemic cause or a disseminated cause. A spinal paraplegia may be due to a focal cause, a disseminated cause or a systemic cause. The focal cause can be there will be a definite area of sensation loss will be there in a focal cause. It may be due to a compression. Compression may be in the due to a vertebral problem like fracture dislocation of the vertebra, disc prolapse, spondylosis, then tumor or deformity of the vertebral column. Then it can be due to a meningeal problem, that can be extramedullary. It can be extradural, dural or intradural. Extradural is leukomic deposit, and for dural, meningioma, pachymeningitis. For intradural, it is neurofibroma. Okay. Then it can be spinal cord problem, that is intramedullary, that is syringomyelia. Or it can be an inflammatory cause like transverse myelitis, or it can be a vascular cause, that is anterior spinal artery occlusion. It may be due to systemic cause, hereditary spastic paraplegia, like then motor neuron disease, subacute campaign degeneration. Then it can be a disseminated cause like disseminated sclerosis, disseminated syphilitic lesion, or okay. Now what are the causes of the cerebral paraplegia? So that can be due to a lesion in the parasagittal region or in the brainstem. Okay, the parasagittal region or in the brainstem. In the parasagittal region, it can be a traumatic cause like depressed fracture of the vault of the skull, subdural hematoma. It can be a vascular cause like superior sagittal sinus thrombosis, and it can be an inflammatory cause like encephalitis, meningoencephalitis. Then it can be a neoplastic cause, or it can be a degenerative cause. And in the brainstem, it can be due to syringobulbia, or it can be due to a midbrain stem tumors. So these are some of the most common causes for the paraplegia. Okay. Now we have to differentiate each cause. For that, first of all, we have to find whether it is a compressive cause or a non-compressive cause. If you understand, if it is spinal cord, then we have to find it is a compressive cause or a non-compressive cause. In a compressive cause, there will be bony deformity will be present, and that will be absent in a non-compressive cause. And bony tenderness will be present in a compressive cause, and that also will be absent in the non-compressive cause. Root pain means it's here we have pain in the back, that is radiating to some other regions, that is exaggerated from straining, coughing, or Okay, so that is this root pain that is present in a compressive course and that is absent in a non-compressive course. So next is a girdle-like sensation. So girdle-like sensation is a burning-like sensation in a small area, in a localized area, like in an area of where in a small area, like sometimes we say in an area we wearing belt in that, like that, a small in a small area there will be a burning like sensation, that is a girdle like sensation, and that is present in the compressive type of lesion and that is absent in non-compressive. And zone of hyperesthesia is present in compressive and that is absent in a non-compressive cause. And onset is gradual in compressive and it is acute in a non-compressive cause, and it is asymmetrical in compressive and it is symmetrical in non-compressive. Next we have to find what if we found that is a compressive cause, or then we have to find it's an extramedullary or an intramedullary cause. So we know that this intramedullary can be intradural or extradural. Intramedullary can be a intradural or an extradural. Okay. So this intramedullary can be so we have to differentiate which is intradural, what is extradural, which is intramedullary. So now see, intramedullary is inside. Here, this is the intramedullary cause. This is extramedullary extradural. This is extramedullary extradural. That is fully out of the dura. This is outside of the dura, which is inside the dura. This intramedullary is inside the dura, and intramedullary is inside the spinal cord. Okay, it will be inside the spinal cord. So now how to differentiate? In an extradural cause, the onset is rapid, and in an intradural and intramedullary, it is a slow onset type of lesion. It's a slow onset. Then spinal tenderness is present in the extradural and it is rare in the intradural and it is absent in the intramedullary. Then root pain is common in extradural and it is uncommon in intradural and it is absent in the intramedullary. And the position sense, for this we must know something basics. We know that the posterior column, this is the posterior column, has a posterior column that is close to the extradural part. So here in an extradural type of lesion, there will be early loss of the position sense. There will be, it is a extradural cause. So here the early loss of the position sense will be there in the extradural, as this is close to the extradural is close to the dorsal column. But in an intradural, as it is not much close to the as the posterior column is not much close to the intramedullary, so there will be posterior sensation will be spared. There will be no spared. Then, but it is early loss in the intramedullary, extramedullary, extradural. The position sense will be early loss. Okay. Next is the pain and temperature is lost in all the three types of in all the three types there will be loss of position, pain and temperature. And now coming to the sacral loss. As we know, see this structure. First is sacrum, next lumbar, then thoracic, then cervical. As the sacrum is most close to the extradural, so there will be early sacral loss in the extradural, and sacral loss also is spared in the intradural. This is most away from the intradura. So sacral sparing was also is also spared in the intramedullary course. Okay. Then bowel and bladder. This bowel is close to the bowel and bladder, that is close to the spinal cord. So bowel and bladder movement, there will be early involvement in the intradural. As it is close to the medulla, spinal cord. So intramedullary lesion, there will be early bowel and bladder involvement, and it is late for the extramedullary course. So now once again, so in extramedullary, the onset is rapid and it is slow for intramedullary and intradural. Then spinal tenderness is present in extradural and it is rare in intradural and it is absent in the intramedullary. And root pain. Root pain is common in extradural. It is uncommon in intradural, and it is absent in the intramedullary. And the position sense, as I have told, the position dorsal column is most close to the extramedullary part. So a position, there will be early loss of the position sense in the extradural, and there also but in intradural course also there will be loss of position sense, but it is spared in the intramedullary course. Pain and temperature loss is present in all the three types. Then sacral loss, as the sacrum is most close to the extradural part, there is early sacral loss, and it is also seen in the intradural, but it is spared in the sacral. Sparing is present in the intramedullary course. And as the bowel and bladder is most close to the spinal cord, there is early bowel and bladder involvement in the intramedullary course, and it is late in the extramedullary course. Okay, so bowel and bladder involvement is late in the extramedullary course, and it is early for the intramedullary course. Okay, next we have to find what is paraplegia inflection, whether paraplegia inflection or whether paraplegia extension. So first of all, in the second stage, so in the in paraplegia inflection, the cause can be a pyramidal. There is involvement of the both pyramidal and the extrapyramidal tract. In paraplegia and in extension, there is only involvement of the pyramidal tract. And hypertonia, that is more in flexors in paraplegia inflection, flexors, and more in extensors in paraplegia and extension. Deep reflex is less exaggerated in paraplegia inflection, and it is more exaggerated in paraplegia and extension. And the clonus is absent in paraplegia inflection, and that may be present in paraplegia in extension. And the mass reflex that may be present in the paraplegia inflection, then that is absent in the paraplegia in extension. This paraplegia inflection and extension that we are telling while coming to the clinical features. So we know that at the we'll study about this more detail in the next part of this next section of this class. So now I will conclude. Thank you.